the other day we were looking at the etiology, pathogenesis, classification, risk stratification, assessment of a patient of pneumonia, community acquired pneumonia. Now it is for us to know how to treat the patient. So we used the port scoring, just recalling the port scoring. Port scoring has got some components. The one component is the age, the other one are the comorbidities, and then you have the clinical findings, and of course you have the investigatory findings. Under the age, take the number as it is. If the woman, just reduce 10 from the age. Under comorbidities, for neoplasia, I give 30 points, liver disease, you give 20 points, congestive heart failure, 10 points, cerebrovascular disease, 10 points, and then renal disease, 10 points. Clinical findings and parameters are altered sensorium, 20 points, respiratory rate increased more than 30, 20 points, low systolic blood pressure less than 90, you use 20 points, temperature hypothermia or hyperpyrexia, 15 points, and then pulse rate tachycardia more than 125, 10 points. Investigations, arterial pH, 30 points, 1 more than 30 is 20 points, serum sodium less than 30, hyponatremia, 20 points, hematocrit low, less than 30, 10 points, blood glucose is high because morbidity in diabetics is more, so that you give 10 points, PaO2 is less than 60, you give 10 points, X-ray evidence of pleural effusion, 10 points. Okay. Now, based on that, it will be classified as class 1, class 2, class 3, class 4, class 5, depending on the summary score. If the score is no predictors are available and everything looks normal, then it's class 1, less than 70 score is class 2, class 3 is 71 to 90, class 4 is 91 to 130, class 5 is more than 130 score. So what I have to do when I suspect a case of pneumonia, clinical examination, and then history taking, an X-ray showing an infiltrate. Immediately not doing anything but try to stratify the patient for treatment purpose. How do I stratify? I use the PORT score, also called PSI, Pneumonia Severity Index. This score classifies the patients as no predictors, less than 70 score, 71 to 90, 91 to 130, and more than 130. So depending on that, now we have 5 classes. Class 1 and 2 have one type of management, class 3 another type of management, 4 and 5 have got a more intense management. So that's what we see in the next slide. Class 1 means no risk factors. PSA score, mortality is 0%, and treatment strategy is outpatient treatment. And the class 2 is there, less than 70 port score, mortality is still lower, they also are treated as outpatients. And class 3, 71 to 90 is the PSI score, mortality is still lower, maybe having a brief hospitalization, and then they can go home. And class 4, of course, you have to admit, because the mortality is around 9.3%, they have to be taken in the medical ward as inpatient. And if you have more than 130, of course, it is a serious pneumonia, and the mortality could be as high as 30%, and you have to admit the patient in the ICU. Okay. Now, if you don't do port score, you can as well do curb score. Curb is what? C is confusion, U blood urea nitrogen, R for respiratory rate, B for blood pressure, both systolic and diastolic. Systolic less than 90, diastolic less than 60, respiratory rate more than 30, 1 more than 30, confusion, and 65 stands for the age. Suppose none of these factors are there, then curve will be 0. If it has got one of these factors, the curve will be 2. If it is curve 0, it is home treatment. Curve 2 is there, short hospitalization. Curve 3 is there, you will have to admit the patient in the medical ward. Curve 4 or 5, you have to put the patient in the ICU. So I have two methods of doing it. Either I do a detailed PSI scoring. If that is not possible, I am in a primary health center or I am in a remote area where all the facilities for pivot and all that are not there. And I can as well do the simple test assessment called the curve 65. Okay. Even some authorities suggest, even if you don't have blood urea, you have all other things are clinical. You can have CRB 65. No access to take blood urea as nitrogen. Till now, no problem. You assume the blood urea nitrogen is normal and score it as 0 and look at the other points. Because hypotension, tachypnea, confusion, higher age always stratifies the patient to a higher thing. So even if urea is not available, I will still be able to classify my patient. So this is very essential rather than trying to do culture, do this, do that, call that consultant, this consultant. First thing is we make the assessment of the patient either with port, if available in an institution, or with curve, or at least CRB. Okay. Now, the old treatment strategy is conservative start with workhorse antibiotic. Like somebody gets pneumonia, earlier days, people used to give them an antibiotic, something like that, maybe a cotrimoxazole or penicillin or amoxicillin, and then send them home. And then if they are not responding, then slowly escalate the antibiotic and then reserve more potent antibiotics for a later phase where patient does not respond. This way, if you do, what will happen is you will lose many patients because this is a very serious condition. The treatment is required immediately, not after 5 days or 4 days, by which time the patient would have progressed a lot. So this traditional paradigm is now discarded. Now, what is the current paradigm or new paradigm? Hit hard and early with appropriate antibiotic. So what is the appropriate antibiotic? I will tell you. Now, we are not going to slowly escalate the antibiotic, wait for 8 days, 10 days, then do this test, that test, and all that. Now, straight away, if the classify the patient and treat the patient with early antibiotic therapy with a powerful antibiotic and short duration. Short duration, I mean 5 to 7 days. Okay, and then de-escalate the antibiotic once the patient is responding. So hit hard, hit early, and then short duration, and come out from the antibiotic use as early as possible. That is today's paradigm. Now the therapy conundrum is, supposing I use very stronger antibiotics, do I get multi-drug resistance? And the patient, if I have a powerful antibiotic to start with itself I have used, I may end up in multi-drug resistance. That may be one viewpoint. The other important thing is immediate treatment is required in this case to prevent septicemia and other. So between the two, objective 2 is more important than objective 1. So that is why we have to give powerful antibiotic for a short period and quick and come out very quickly. Now, if you see the effect of traditional approach, that means slowly escalating the antibiotic, starting with cotrimoxazole, penicillin, or amoxicillin, the mortality rate for CAP is 17%, for hospital-acquired pneumonia is 34%, for the institution-acquired pneumonias with ventilator pneumonias and all, it is 45%. This again is a study there, the reference is given. So with this background of the data, we are not going to wait with the traditional approach. So what are the new data saying? New data says, don't wait for any other results or sputum results or anything. So there is a comparison in this study. What they did was switching after susceptibility results. So start on a milder antibiotic, wait for 48 or 72 hours, then increase the antibiotic. That is one strategy. The other strategy is straight away you start, depending on the classification of the patient, you start the antibiotic, powerful antibiotic. And the difference is from 52%, the mortality is brought to 18%, which means the new strategy does work, and that should be the attitude. CAP treatment consensus today is risk assessment must be done. Early antibiotic selection. Change in the treatment is required and is driven by the local pattern of the organisms. Hit hard and hit early. Short duration as far as possible. De-escalate when and where possible. This is the consensus, international consensus on treating pneumonia today. Now, there is one thing that has called OPAT. What is OPAT? OPAT is OP parenteral antimicrobial therapy. That means you prescribe them twice a day. You have to give ceftriaxone or cefixime or whatever is the injection. Patient need not get admitted. He comes and just sits there in one of the chairs in a comfortable lounge in a room, and the nurse comes and gives the injection. 15 minutes the patient waits and goes. So much so, the hospital cost is avoided, and hospital-acquired other infections are avoided, and inconvenience to the family is avoided, and patient gets antibiotic in the parent. This is very much in vogue in Western countries. OPAT. This is called OP parenteral antimicrobial therapy. This way, you are not robbing the patient of parenteral treatment, and you are not admitting him up. So this is the via media approach, giving the best to the patient without the cost, inconvenience, and infection risk of the hospital. So this OPAT is very important for us. OPAT is all you require is have 2 or 3 chairs in your good cozy room and with newspaper and air condition, or without air condition, some window. And the patient comes and sits there, nurse comes and already the IV line is there. Inject the antibiotic. Don't send him away, because some of these may produce a little reaction after some time. Half an hour or 15 minutes, make him wait. He or she will go. This is a very convenient method. This OPAT should be practiced whenever you are thinking of parenteral antibiotic treatment. Now, what are the choice antibiotics I have? This you must have a very clear idea. There should not be any confusion. Yeah, I can stop also and explain. The first group of drugs are called macrolides. Macrolides, and doxycycline is not a macrolide, but that is also considered as the first group of drugs. The first group of drugs are doxycycline and macrolide. Macrolide M. Macrolide we hereafter we call it as M. Doxy we call it as dox. Okay. What are the M's we have? We have azithromycin, clarithromycin, erythromycin, and telithromycin. Erythromycin is not much used in our country. Erythromycin, clarithromycin, azithromycin, very much used. In fact, abused also. The practitioner, the moment sometimes somebody gets some bronchitis, he puts on azithromycin. So that way, azithromycin and clarithromycin are rather abused drugs. Erythromycin, today we are not using much. In the erythromycin, you have 2 sorts, estrelate and then erythromycin stearate and estrate. Between them, the stearate produces biliary spasm and then cholestatic jaundice. So be aware of that. When you use erythromycin, it can end up in cholestatic jaundice. Because when I was a house surgeon, my niece is around 10, 12-year-old girl, and she had a upper respiratory infection. I have put her on erythromycin stearate. Then after 3 days, she developed jaundice. I did not know what it was because I was just a house surgeon. Then I took the patient to my assistant, my niece to my professor. And what did you give? He asked. I gave erythromycin. What salt you gave? He asked. Then I said, I did not know what salt. Then bring that. You see, this particular one causes cholestatic jaundice. You stop it and switch to estrelate, it will disappear. This is why I am telling. This is an experience which I got myself when I am treating with sort of without full knowledge what has happened. So I was afraid why jaundice has come in this lady, in this girl. But that is the story. So to tell you, when you use erythromycin, be careful to use Eustolate, erythromycin eustolate, not the any other salt. Okay. Azithromycin, no problem. Clarithromycin also, only one salt. So what are the first group of drugs? Macrolides, doxycycline. Now, what is the second group of drugs? Respiratory fluoroquinolones. We call them as FQ. Fluoroquinolones, respiratory fluoroquinolones. Why I say respiratory? Why I say respiratory fluoroquinolone? Norfloxacillin cannot be used. The ofloxacillin cannot be used. They are not respiratory fluoroquinolones. They are GI, urinary tract, and other areas. And then eye, ear, those infections. So these four are the respiratory fluoroquinolones. Levofloxacin, moxifloxacin, gatifloxacin, trovofloxacin. Trovofloxacin, we don't use very much in our country. Gati, moxi, levo, we use. So when we say fluoroquinolones, FQs, we have three drugs. Levofloxacin, moxifloxacin, gatifloxacin. This is the second group of drugs. And the third group of drugs are called the beta-lactam antibiotics. Beta-lactam antibiotics are ceftriaxone, cefotaxone. And beta-lactam inhibitors, they are sulbactam, tazobactam, and pipers. If you are suspecting of beta-lactam as a resistance, then you have to use beta-lactam inhibitors. They are sulbactam, tazobactam, and pipers. Okay. So now, what is the drug armamentarium I have got? No other drugs. Remember, cut off all other drugs. Metronidazole, this, that, or some other cephalosporins and all that will come. What is all required is macrolide, azithromycin, clarithromycin, erythromycin. Fluoroquinolones, levofloxacin, moxifloxacin, gatifloxacin. And beta-lactams, ceftriaxone, cefotaxone. Beta-lactam inhibitors, sulbactam, tazobactam, pipers. Okay. When you under beta-lactams, you have got one more oral drug or parenteral drug is amoxicillin with clavulanic acid. That can be used. Amoxiclav is a beta-lactam antibiotic. That's not listed here, but you can use amoxiclav also can be used. Okay. Now, I must know what is the dosage I have to use. Without knowing the dosage, I cannot treat the patient. Doxycycline 100 to 200 milligrams, either oral or IV, BID for 7 to 10 days. Doxycycline generally is used for a prolonged period because it is a less powerful drug. Azithromycin single daily dose 500 milligrams, OD either IV or peroral for 7 to 10. Clarithromycin if you use, depending on the body weight, less than 50 kilos, 250, more than 50 kilos, 500 milligrams, BID, peroral 7 to 14 days. Telithromycin we are not. Levofloxacin 750 milligrams tablet is available, peroral or IV, OD for 5 days. Gatifloxacillin, moxifloxacin, same dosage, 400 milligrams, 5 to 7 days. Gemifloxacillin, 320 milligrams, peroral for 5 to 7. Here, the floxacins are used for a shorter duration, 5 to 7. When you are choosing macrolides, you use 7 to 10 days or 7 to 14 days. That is the general rule. Amoxiclav, 2 grams of amoxicillin plus 125 milligrams of clavulanic acid. So what you give normally is 500 plus 120. That is not adequate. So you have to separately take amoxicillin extra, 625 plus another 1,500 of amoxicillin. That becomes 2 grams plus 125. That is the way you have to. 625 tablet of amoxiclav and 500 milligrams of capsule and 1,000 milligrams. That is the dose you have. Otherwise, it will not respond. This is why hit hard. What we are saying is hit hard. Don't give just half a tablet of amoxicillin. It's not going to do anything. And on the contrary, it will endanger the patient. Ceftriaxone, minimum of 2 grams BID for 3 to 5 days, plus peroral 3 grams of any cephalosporin. Entropinum, if you decide to give meropenem, entropinum, and all that, in case of Pseudomonas, you have to give 1 gram OD IV or IM for 7 to 14 days. Why the treatment duration is longer? Because we are going to use those drugs in severe cases. That is why the treatment duration is long. Okay. Now, what is my empiric antibiotic treatment? Empiric means without any culture result, without depending on any bacteriology, we are. A patient is healthy, he has no risk factors, his port score is zero, his carb score is zero, and there is a there are no factors for drug resistant yes pneumonia. It does not have any factors related to DR is drug resistant streptococcus pneumonia. Then only single drug, either a macrolide or not. Macrolide, I have told you, 3 drugs: clarithromycin, azithromycin, erythromycin. Doxycycline, 100 milligrams BID, one of them. The first category of patients, the drug to be used is only either macrolide or doxycycline. Do not combine in category 1 and 2 or curve score 0 and 1. Then you have to give only macrolide. It's a healthy fellow, had a pneumonia, no other risk factors, port score is 0, and then curve score is 0 or 1. He classifies only for domiciliary home treatment, and the drug that I use, either a macrolide or a doxycycline. Fluoroquinolones, beta-lactams will not come into picture. Okay. Presence of comorbidities, elderly patient or diabetic patient has got other comorbidities. Use of my antimicrobials, already he says, no, 3 weeks back, I was treated for urinary infection. I had some antibiotics, or I will be now and then taking amoxicillin whenever I get some sore throat on my own without doctor's prescription. Many people do that. Then, of course, he is a candidate for more intense treatment because he is already exposed to antibiotic. And where there is a high rate of infection with macrolide resistant pneumonia, then macrolide may not work. Then you have to use respiratory fluoroquinol. What are they? Gabifloxacillin, moxifloxacillin, levofloxacillin, gatifloxacillin, or beta-lactam. High dose amoxicillin, that is 2 grams of amoxicillin with 625 milligrams, 125 milligrams of clarithromycin, ceftriaxone, 2 grams BID, ciprodoxime or cefurolzine, one of the 3rd generation cephalosporins, plus a macrolide or. Now what happened? We have used a respiratory quinolone plus beta-lactam or beta-lactam plus macrolide or dox. First group 1 drug, second group 1 combined. Or you use both the drugs from the second group, fluoroquinolone, beta-lactam, second and third. This is for the people who are in the grade 3 of the port score or curve score 2 and 4 and 5 curve score, they qualify for higher treatment. Likewise, 4 and 5 of port score, they qualify for higher treatment. Okay. This is non-ICU patient. That is a fellow who is admitted in the medical ward. Respiratory fluoroquinolone, levofloxacillin, a beta-lactam has to be given or a macrolide has to be added. If I choose to give the beta-lactam, ask him to come for the outpatient injection, OPAT. And then if the patient is allergic, then you can do other options. You can use antropinum also. It's one of the options for patient allergic to penicillin or beta-lactams. Empiric treatment of inpatient in the ICU. That is the 3rd category of patient. Here, beta-lactam must be used, and then along with that, you use either a fluoroquinolone or an azithromycin, either a macrolide or a fluoroquinolone combined with beta-lactam antibiotic, preferably parenteral. Here, no oral, at least until the remission occurs. Penicillin allergic patients, azithromycin and fluoroquinolones can be combined. Now, suppose I suspect Pseudomonas, depending on the pattern, or he had urinary infection earlier with Pseudomonas, now he has bacteremia probably and Pseudomonas infection, and the sputum also is suggestive of Pseudomonas. Then you have to use piperacillin tazobactam combination, piptaz, it is coming, all of you know. or cifixime tazobactam. Combination, any other carbapenem, imipenem, meropenem, plus either cipro or leaf. That is a beta-lactam antibiotic for which Pseudomonas will be sensitive, like piperacillin tazobactam combination, plus the fluoroquinolone, cipro, levo, or gatia. Second option is above beta-lactam, plus an aminoglycoside you can bring in, which you are not put in the group, because this is reserved for people. What are the aminoglycosides we have? You can use garamycin, you can use kanamycin, you can use netilmycin, any one of the aminoglycosides you can. Better thing is netilmycin may be a better option, plus azithromycin. If you are using aminoglycoside, the patient is really sick, you can have 3 antibiotics, one beta-lactam, one aminoglycoside, one macrolide. Okay. Now, above beta-lactam, third option is beta-lactam, aminoglycoside, and an anti-pseudomonal or anti-pneumococcal fluoroquinolone. And if penicillin allergic, of course, azithromycin and beta-lactams can be used. These are the variants. Now, there is another group of fellow who can be community-acquired pneumonia due to methicillin-resistant staphylococcus. This is a problem case. A fellow with methicillin-resistant staphylococcus, MRSA, community-acquired pneumonia, then the drug is not those won't work on that because it's methicillin-resistant. So naturally, you have to use vancomycin or linezolid. Vancomycin or linezolid for methicillin-sensitive MSSA, not MRSA, beta-lactam can be used along with fluoroquinolone. Specific therapy with penicillinase-resistant semisynthetic penicillins or cephalosporins can be used. Now, to summarize again, I have a patient who is healthy, he is qualifying for outpatient treatment and he is having no comorbidities, he belongs to grade 1 of curb or port, and then he can be treated in the outpatient. And I have only one drug to be given. What drug? Either a macrolide or doxycycline. If I use doxycycline, 100 milligrams, 200 milligrams BID. If I use azithromycin, 500 milligrams single dose per hour, because it is a house treatment, we will not prescribe parent. If he is in the other category, moves to the next higher category, then I am bound to combine a beta-lactam with macrolide or a fluoroquinolone with macrolide. Any one of the two can be given. Then preferably the beta-lactam could be an injectable one. Ask him to come for the OPAT. If he goes to the ward and he has admitted, then beta-lactam is there, fluoroquinolone is there, macrolide is there. Any two of the 3 combinations we can. If he is an ICU patient, we have to use all the 3. Macrolide has to be there, fluoroquinolone should be there, beta-lactam should be there. If he is having Pseudomonas, tazobactam with piperacillin, sulbactam with piperacillin, piptaz, these are the drugs. If he is methicillin-resistant fellow, vancomycin, linezolid. Very clear directives. We can't be fishing with this antibiotic, that antibiotic. Go straight with this recommendation. You will not be in trouble. Then how long I have? The minimum duration is 5 days, maybe 7 to 10. Okay, now what is the guideline? If the patient is febrile, after the fever stops, minimum of 2 to 3 days you have to continue the antibiotic. One indication to reduce the antibiotic from oral to parenteral to oral or stop the antibiotic is the fever. If the fever is not there for 24 hours, from then you observe for 48 to 72 hours. No fever, can drop the antibiotic. That is the duration. Suppose fever continues until 7 days, and 7th day only he has got fever remission. Then you have to give for 10 days. So the duration is minimum 5 days. Suppose fever disappears first day itself, then you can't stop on 3rd day. You have to give minimum of 5 days. That is first rule. Having said that, once the fever stops, count for 2 or 3 days and then stop the antibiotic. Okay. Longer duration of treatment is required. Initially, it was not against. Pathogen is not identified and complicated by extrapulmonary infection. There is an septic arthritis, there is septicemia, there is pyelonephritis, there is some other organ is also having sepsis, then you have to need a longer duration of. This is a beautiful slide. This summarizes everything. The first bar is 0.5 hours. That is 30 minutes of symptoms and diagnosis. You started the antibiotic. The mortality is around 83. The survival is around 83%. And if you give it after 6 hours, the mortality is 45%. Survival is only 40%. That means 60% of people die. This is a beautiful study published, The Speed of Delay. It's called, the title of the article is Speed of Delay. Delay is what speed? Delay is not having speed. The speed of delay is how fast the delay will cause a problem. In class, this is not in class 1, this is not in class 2 or 3, in class 4, class 5 patient. That is why I must understand whether my patient belongs to class 4 or class. If he's class 4 or class 5, he runs a mortality risk of 60% if I delay the antibiotic. If I start immediately, I can reduce the mortality to 20% or even less. So the message is a delay in hours from the onset of hypotension or any other signature of 4 or 5. Whenever you have 4 or 5 class, the patient presents with hypotension, you must start the antibiotic, particularly at least 2 drugs, one beta-lactam, one fluoroquinolone, preferably parenteral or beta-lactam, and macrolide, preferably parent. Saves lives. So this message, this slide has got a wonderful message, and it should change the way we practice medicine. Okay. Now I am summarizing the capital. Outpatient treatment, any one of the 3 you can use. Macrolide, doxycycline, even fluoroquinolone. We have said first group of drugs, macrolide, doxycycline. Somebody wants to choose levofloxacin as an outpatient treatment also. 750 milligrams BID, levofloxacin, fine. No problem. You can give any one of the 3, only one drug. Patients in general medical ward, that is those who are in the category of 3. 1 and 2 have gone there. And general medical ward, 3rd generation cephalosporin, by needle, OPAT you can give, or if is admitted already, give that and combine macrolide. Or give beta-lactam plus macrolide or beta-lactam plus fluoroquinolone. Generally, fluoroquinolone alone in milder patients in general. ICU patients, 3rd generation cephalosporin, macrolide, fluoroquinolone. Beta-lactam inhibitor drug, particularly when there is beta-lactam sensitivity, beta-lactam inhibitor drug is required, or macrolide and fluoroquinolone. These are IDSA guidelines, Infectious Diseases Society of America. These are guidelines are still, these are the ones. Now I am summarizing in the next slide. Whatever we have read. Now, what is my duty as a important member of the community, as a physician? I must identify pneumonia because it's a treatable condition. Supposing you identify stage 4 cancer, what the big thing you are going to do the patient? Not much. Only palliation. If you identify pneumonia, you win, he wins. It's a win-win situation. You can treat the patient. You can boldly say, yeah, I have treated pneumonia. And patient says, oh, he has screwed me about it. Class 1, outpatient treatment, azithromycin, clarithromycin, or doxycycline. One of the 3. Class 2, also OP treatment. Fluoroquinolone, beta-lactam plus macrolide. This is the OPAT fellow. Beta-lactam by the vein, macrolide by the, or beta-lactam. It's dox. Or if you want to use a single drug for that class 2 fellow, fluoroquinolone is better. Okay. Class 3, this is OP or IP, depending on the patient's affordability. IV fluoroquinolone, IV beta-lactam plus azithromycin, or azotenum if it is resistant, and then fluoroquinolone. One of the combinations. Class 4, you have to admit him under the medical ward, fluoroquinolone plus azithromycin, 3rd generation beta-lactam plus azithromycin, entropinum plus macrolide, any one of the combination. The preference is First line is first preference, second line is second preference, third line is the third. And those in the ICU, beta-lactam antibiotic third generation with azithromycin, fluoroquinolone, and in case of Pseudomonas, carbapenem, sulbactam, or tazobactam. In case of methicillin-resistant staphylococci, CAMRSA, you have to use vancomycin and linezolid. In a patient who is not responding, add the third drug also, try. If it is still, the fever is swinging, you can remove one of those three, the macrolide, and add aminoglycoside. So if you want to give three drugs, macrolide, fluoroquinolone, beta-lactam. Patient responding, good. Otherwise, drop macrolide, keep fluoroquinolone and beta-lactam, add aminoglycoside. You have won the battle because it would have covered all the spectrum. In the meantime, your culture results also would have come. Class 1 patient, class 2 patient, no culture, outpatient. Class 3 may or may not do a sputum culture. Class 4, class 5, you must do a culture. Because they are in a severe grade and we would like to know the antibiogram, and then depending on that we need to treat. Once the results are in, you adjust your antibiotic. From the beginning, if you are suspecting Pseudomonas, straight away go for meropenem, carbapenem, imipenem, like that. No, that is important. If you are suspecting methicillin-resistant staphylococci, then be on the guard, use vancomycin or linezolid. Okay, this is the summary. So you must have got it very clearly what I am saying. Now, how do I prevent this particular pneumonia? Okay. How do I prevent pneumonia? Because most important is I am not a curer of disease. I am a person who dispenses health. Physician means, doctor means the one who prevents disease, not the one who treats. Treatment is only lower grade doctors. The highest grade doctor prevents the disease. So your first attempt is as a preventive doctor, not as a curative doctor. What do? Stop smoking. If patient is not smoking, then COPD and other respiratory infections. Influenza vaccine must be given to everyone during the flu time. If COVID things are there, give COVID booster also. Now, pneumococcal vaccine. Pneumococcal vaccine, everyone in the community above 65 must get pneumococcal. All COPD patients, heart failure patients, immunocompromised patients, uncontrolled diabetics must get pneumococcal. How many of you follow? Go and check in the OPD. Less than 60 years, 65. How many physicians have prescribed pneumococcal vaccine? Leave alone. How many physicians above 65 have taken pneumococcal? You don't follow guidelines. Guidelines will work only when they are applied and followed. Otherwise, guidelines will be in the paper and things will go on. Don't be a bad doctor. You have no right to be. Your parents have spent a lot of money. Country is spending a lot of money to educate you. Community is expecting so much from you. You have no business to be a bad doctor. Get a bad exam. Follow the guidelines. Respect the guidelines. Like one respects Bhagavad Gita or Bible. Guidelines say everybody above 65 must have pneumococcal vaccine once. Single shot in life. It is not every 5 minutes to give. Okay. This pneumococcal vaccine, under 65, the conditions are immunocompromised, diabetics, smokers, heart failure, COPD, must get the pneumococcal vaccine. Tomorrow onwards, you start the vaccine. This lecture is not to give you, some hardcore brain cell, gray cell knowledge. That should come to your pen and then use it. Isn't it? So, and also every influenza season, flu vaccine. With this, the incidence of pneumonia comes down. Even if some gets, the morbidity and mortality will come down. The impact will come. Okay? 70% of us have pneumococci in the respiratory tract. If you don't have any symptoms, He doesn't have any symptoms. I go and culture your throat. They report staph pneumonia, S pneumonia, streptococcus pneumonia. It is a commensal. When it gets into the lower respiratory tract and under conditions, favorable conditions, it produces this. So that is why pneumococcal vaccine is so important. And the highest morbidity in those who are more than 65, that don't neglect that population. Without any risk factor, one risk factor 65 itself is the biggest risk factor. They don't require any other qualification to get a pneumococcal vaccine and regular influenza stuff. Okay, another way, how can I prevent complications? Start the antibiotic within the first 1 hour of diagnosis. Don't delay it. And then assess the oxygen status and stratify the patient. Okay. When do I switch to oral therapy? I already told you. When there is a defervescence of fever and when the WBC count is coming to normal from 20,000, 25,000, when the GI tract is good, no vomiting, no diarrhea, and then the cough and dyspnea have improved, you can bring down de-escalate the antibiotic. The teaching is hit hard, hit early, and come out quickly. Don't be continuing. So this IV injection you may have to take for 5 weeks like that. You should not. So you should de-escalate it, and then I should know when to come out. Okay. Now, what are the complications of CE? Yeah. What can happen? Hypotension and septic shock. Dreaded complication of pneumonia. Then what I should? You should be under constant, once admitted, every 2-hourly blood pressure monitoring and possible continuous monitoring will be better. 3 to 5% of people with pleural effusion will have complications. So if the pleural effusion is there, be aware that you are in for some complications. And particularly if the pleural effusion tab is pus, you are in for more. So empyemothoracis occurs in 1% of the patient, the pleural space. Lung abscess due to destruction of the lung, chronic suppurative lung disease, I told you, chronic suppurative lung disease is bronchiectasis, lung abscess, secondary lung abscess and tuberculosis, pneumonia not properly treated going into lung abscess, and empyema. Okay, single site, you have the lesion. Then it is anaerobes, pseudomonas, multiple means staph aureus is the cause. Multiple areas are involved. Septicemia can lead to brain abscess and liver abscess. One of the causes of liver abscess is pneumonia, and then multiple pyemic abscesses. You can have. I had one patient who came with pneumonia. He's in the grade 4 or grade 5 category. After 3 days, he started getting bumps all over the skin, multiple pyemic abscess because of septicemia. He's a diabetic patient, and his renal function also is compromised. That's the reason he went into. Now, pneumocystis carinii, PCP pneumonia. This is not a very common condition, but you should know about it. Important cause of pneumonia in the severely immunocompromised people. Doesn't occur in you and me, in people who are HIV positive or severely immunocompromised. It is a sort of pneumocystis carinii pneumonia. It is one of the atypical pneumonias, not the primary viral atypical pneumonia, but this is an immunocompromised people. Classically, PCP pneumonia presents with mild fever, dyspnea, non-productive. Diagnosis usually histological and using silver staining of the sputum, and treatment is not any one of these. Pentamidine or Potrinus responds only to those 2 drugs. If you suspect PCP in an immunocompromised patient, suspect PCP and do a sputum examination of silver staining, confirm and give cotrimoxazole and pentamidine. Then, viral pneumonias are generally not part of community-acquired pneumonia, but to complete it, pneumonia in the normal host are usually viral pneumonias. That is, an young child comes, pneumonia comes. Not usually bacterial. Influenza A, influenza B, respiratory syncytial virus, adenovirus, parainfluenza. These are. I have an immunocompromised course, known HIV patient. Then what are the possibilities? Measles, HSV, simplex infection, cytomegalovirus, HHV6, influenza virus can cause a primary viral pneumonia, cause partial paralysis of mucociliary skeletal, increased risk of secondary bacterial LRTA. SRS pneumonia is a known complication following influenza. These are the other things. How to win the war of pneumonia? How best, as a physician, I can win the war of pneumonia? Is a big war. Early antibiotic administration, empiric antibiotic use as per the guidelines, port scoring, PSA scoring and classification. I should not forget. Early hospitalization for class 4 and class 5. Change in the antibiotics as per the pathogen sensitivity and pattern in 4 and 5. Decrease or smoking cessation, advice and counseling on smoking. Arterial oxygenation assessment in the first 24 hours. Blood culture collection in the first 24 hours in people who are 4 or 5 category. Pneumococcal and influenza vaccination and stop smoking. If one observes this slide, entire summary is early antibiotic administration. Within first 4 hours, I have shown you the mortality as a 60% in grade 4 and grade 5 patients when you give antibiotic after 6 hours. It's as good as not giving. Empiric antibiotic treatment, depending on the category of the patient, macrolide or doxycycline. First level, beta-lactam or fluoroquinolone. Second level, combination. Third level, then all the 3 drugs, beta-lactam, fluoroquinolone, macrolide, if necessary, aminoglycoside, the pinams, carbapenem, meropenem, tazobactam, and those drugs, and vancomycin, lyrizoline, the result. Aminoglycoside is an add-on. Port scoring, at least curb scoring, at least you forget CRB score is 65, you have to. Early hospitalization for 4 and 5. Don't admit the grade 1 and 2 fellows. Change the antibiotic as per the antibiogram. Smoking cessation must be taught and advised. Arterial oxygen assessment must be done. Blood cultures and BP examination should be followed. Pneumococcal and influenza vaccination should not be forgotten. Smoking must be stopped. Okay. Now, I have beautiful exercise for my own practice. I will share some of those exercises with you. This will be very interesting. The T there is the trachea, AK is the aortic knuckle, A is the root of aorta, L is the lung, H is the heart, LI is the liver, S is the spleen, R is the rib. Just to identify the structures in a normal X-ray. So you have to, what I have to do? Look at the trachea, aortic knuckle, aortic root, lungs, both sides, heart size, liver and spleen shadows, and the ribs. Left lower lobe, mild pneumonia. You see the right X-ray on the right side may be dubbed as normal and passed away if you are not careful. But there is an infiltrate in the left lower zone. There is an infiltrate in the left lower zone, as you can see there. And now I come to the next slide. Lobar pneumonia, right upper lobe is involved, complete upper lobe, and there is a black shadow below that is compensatory emphysema. The left lung also is showing compensatory emphysema, and then left lung complete. Left lung, all lobes are involved. Total pneumonia there, panlobular pneumonia on the left side, and a severe compensatory emphysema is there. The shadow below the diaphragm is the stomach shadow, gas shadow. Okay. Now, you have got PA and lateral views of the same patient. This is the right middle lobe consolidation. You can see paracardiac opacity is there, And you see on the lateral view, it is a typical middle lobe involvement. Upper lobe and lower lobe are not involved. Typical middle lobe involvement. This is lateral view. When you suspect middle lobe involvement, you require a lateral view also. That is why you always take an AP and lateral. Now, this one is right middle lobe. Early right middle lobe consolidation will look like that. It is something like a little loose, and then later on it becomes, more solidified. Early consolidation. Lobar versus segment. The left side picture is lobar, and the right side picture is only the segmental pneumonia of the lower lobe. The other one is middle lobe lobar consolidation. Left side is middle lobe lobar consolidation. Right side is segmental consolidation. You can see nice. Now you see this is lobar pneumonia bilateral. Both right side as well as right side. The middle lobe there and right side the upper lobe is involved. The right side is the middle lobe and left side is the upper lobe is involved. Bilateral multilobar involved. Who is such patient? Usually immunocompromised patient, diabetic patient, elderly patient, those who have aspiration pneumonias, multiple pathogens, they have multilobar involvement. When I say multilobar involvement, I must ask the history, whether any aspiration occurred, whether the patient is an epileptic, whether he had unconsciousness, whether he aspirated any fluid due to anything, or he is drowsy, alcoholic, drug user, immunocompromised. This is the thing. Then left upper lobe pneumonia on the other side. You can see typical left upper lobe consolidation. You can see, and you can see beautiful special forms of consolidation, lingular consolidation. On the left side, you can see pericardiac consolidation there, lingular consolidation. And you have an air shadow in the pneumonic consolidation there. And that air shadow is called pneumatocele. Pneumatocele in the left lower lobe consolidation. Then you see round pneumonic consolidations. You see in the upper lobe, right upper lobe, a round consolidation, something like a coin lesion, suspecting malignancy. But the history is very short. Patient came with fever, and patient had all the symptoms of pneumonia, and he responded to the treatment. The shadow disappeared like ice. So that is the round shadow symptoms. Can occur right upper lobe, right lower and left lower lobes. You can see rounded shadows there in case of pneumonic consolidation. Now you have special forms of pneumonia, diffuse alveolar pneumonia on the left side, something like a heart failure. It looks as though the heart failure plethora like, and aspiration pneumonia is also usually in the lower lobe because the tracheal direction is like that. Aspiration pneumonias, not upper lobe. Tracheal aspirates cannot go to the upper. Lower lobe pneumonias, bilateral, history of aspiration. X-ray will be like this. Then there is what is called PCP pneumonia, pneumocystis carinii pneumonia, very mild, vague, patchy, and cytomegalovirus is also a differential diagnosis. Radiation pneumonia. So people who undergo radiation or breast cancer or any other chest disease related radiations they end up with pneumonia. It is parahylar and paramediastinal. The shadows are not in the periphery. How you distinguish radiation? Radiation, does it involve a lobe pattern, not segment pattern, does it involve the periphery of the lung, outer 2/3 is spared, with the central 1/3 of the lung, parahylar, paracardiac, paramediastinal area only is affected in radiation. Then you have got empyema in the lung. So there's a pus in the pleural cavity. We know that it is pleural effusion. When we tap, it is pus. So it's empyema in the left lung, left pleural space. And you see the lung abscess there, a very thick-walled abscess you can see here. The thick-walled cavity is there. The thick-walled abscess due to lung abscess. Untreated properly, not treated. Then you have empyema of the right lower lobe, and you have got the right lower part of the lung. In the pleural space, you can see the CT also, the empyema fluid encircling in the right chest. Okay. Now, mycoplasma pneumonia, X-ray looks very light, and it's walking pneumonia. Patient will have mild symptoms and will not have any fever also very much. This is called walking pneumonia, MCP, mycoplasma. And so secondary consolidation, the right. And what happens is the right upper lobe consolidation, typical right upper lobe, completely consolidated mycoplasma pneumonia, and mycoplasma pneumonia will have extra pulmonary manifestation, like skin manifestation. Can you appreciate those erythema multiforme there in the X-ray? Can you see the X-ray in the hands? Can you appreciate the erythema multiforme? Can you see? Yeah. You can see the erythematous patches. Why it is called multiforme? Because the various forms are. Red and various forms, it is different from erythema nodosum. Erythema nodosum is usually painful, and erythema multiforme is painless. And it's not nodular, it is more macular and macropapular, and there will be central clearance, and surrounding ring of redness will be seen. This is classical of mycoplasma. And chlamydia pneumonia, usually, in children, diffuse pneumonitis occurs, and panbronchiolitis. So you see all the bronchi have got the infection there. Panbronchiolitis will be there. Rare types of pneumonia, psittacosis, and bilateral involvement in psittacosis, pigeons and all the bird pneumonia there. Legionella pneumonia, very blotchy and completely both the lungs are. So one of the dangerous pneumonias is Legionella pneumonia. And finally, this slide is also very important. You can read Hindi, I don't know whether you can. Shrotram Shrutenaiva Nakundale Danena Panir Natukankane Vibhatikaya Karunaparam Paropakarena Nachandanena. What does it say? Famous poetry from Bhartrihari, a great poet, humanitarian. What he says, Shrotram, the ear, is glorified not by earrings or iPods or these ones. It's not glorified by diamond studs, by carefully listening and applying the knowledge. The ears are there to receive and apply what you have to say. Shrotram Shrutenaiva na kundalena. Shrutenaiva na kundalena. Not by ear organ. The hand is not glorified by the Apple Watch or golden bangle or diamond wrist guard, wristband, and all that. By giving whatever you have. Danena panir mutukankani. Vibhatikaya. The body is not glorified by perfumes, silk dress, suits, and all sorts of great, costly things. But when you help others, the body is glorified. Paropakarena nachandanena, not by decorations. Okay. Beautiful message. Usually I end up with a message. Hearing whatever you have heard that glorifies the ears, nay diamonds or earrings, giving to the needy enriches the hand, nay golden bangles, to be kind and sympathetic and helping in all possible ways by properly treating pneumonia, enriches the beauty of your body as a doctor, not by perfume or sandal paste. It's available on the website. So see that. So 1 hour exactly it took. We can stop.